All right, we are going to do our second zebra lesson. So these are going to be on pheochromocytoma and then its associated disorders. Pheo is a zebra disease, but man, does it show up often on a lot of your board exams, whether it be shelf exams or your step exams. So do some of these associated disorders we've talked about. Actually, every single one that I'm going to talk about has either showed up on my step one or my step two. So they're relatively high yield, even though you probably will not see them in real life. All right. Objectives. We'll discuss the physiology of Pheos, discuss the biochemistry of how norepi and epi get made. We'll discuss the clinical presentation of a Pheo. We'll discuss the management. We'll do a brief slide on the associated disorders, and then we'll do a putting it all together. So this was the first case I presented. So we'll go through it and see what you come up with if you didn't answer this on Instagram. So we have a 37-year-old woman presents to the emergency department with episodic headaches, palpitations, and profuse sweating that have been occurring for the past several months. She also reports recent episodes of muscle weakness. Her blood pressure is 192/108, and her heart rate's 112. Physical exam is otherwise unremarkable. Her lab studies show a sodium of 139, potassium is 2.9, chloride 103, bicarb 25, glucose 102, creatinine is 0.8. Further testing reveals markedly elevated plasma metanephrines. Urine potassium excretion is low. Which of the following best explains the patient's hypokalemia? Is the patient hypokalemic due to increased gastrointestinal potassium loss, renal tubular dysfunction, transcellular shift of potassium, or an aldosterone-producing adrenal adenoma? So pause your screen and consider, and then we'll discuss. So this is going to be due to transcellular shift of potassium. So really, when we think about this, we see the paroxysmal hypertension, headache, palpitations, and sweating. These are classic of Pheo, and we'll talk about why the patient is having those symptoms as we kind of go through. But remember, pheochromocytoma, I'm just going to set the stage for us. It's a tumor that is secreting norepinephrine and epinephrine. Those are my sympathetic nervous system activating agents, right? My sympathetic nervous system neurotransmitters. They're going to activate my beta and alpha adrenergic receptors, and it's going to lead to increased blood pressure. It's going to cause vasoconstriction of my vessels in my brain and cause headache. It's going to increase my fight or flight. We're going to get palpitations. We're going to get sweating. And it shoots off the norepi and epinephrine in kind of spontaneous little bursts. And so we'll get paroxysmal, right? They'll have bursts of these headache, hypertension, palpitations, sweating, tremors, and then it will go back to normal. And they'll go and up and down and up and down. So the labs will see elevated plasma metanephrines. We're going to talk about these in a second. And then we can see hypokalemia with low urine potassium. The reason for this is with this catecholamine excess will bind to beta-2 adrenergic receptors, and that upregulates the sodium potassium ATPase, which shifts potassium into the cells. Remember, we pump 3 sodium out, 2 potassium in. This leads to a transcellular shift. Remember when I did my pulseless electrical activity lecture, I talked about ways that we combat hyperkalemia, right? We give calcium gluconate or calcium chloride first, and then the second step was that transcellular shift. We normally use insulin plus glucose, but I also told you, hey, we can use albuterol in really high doses, right? Albuterol is a beta-2 agonist. When we give beta-2 agonists in high enough doses, it does cause transcellular shift. So really, if this tumor is secreting enough norepi and epi, especially epi that loves binding to the beta receptors, we can get enough of a binding that we can cause that transcellular shift. Now, a lot of people on this question, it was actually split evenly. I think 46% picked Pheo, 46 hyperaldosteronism, and then the rest of the people picked other options. But really, the difference here is in primary hyperaldosteronism, also called Conn syndrome, right? That is a adrenal tumor in the zona glomerulosa that's secreting too much aldosterone. Aldosterone will also cause hypertension. Maybe it might cause some headache. It would be weird to see palpitations, sweating, tremors, like those kind of sympathetic activation via aldosterone. That's not really the mechanism of aldosterone. It doesn't have the sympathetic activity. The other thing that points me away from that is the fact that the urine sodium or the urine potassium was low. Aldosterone's job, it keeps sodium in water, it pumps out potassium and H+. So if this was Conn syndrome, I would expect the urinary potassium to either be normal or probably likely high. The fact that the urine sodium or the urine potassium was low tells me that this is probably not Conn syndrome, and instead we're shifting potassium into cells via this pheochromocytoma, and then the renal system is appropriately holding on to potassium so we're not dumping it into the urine. So again, I kind of just explained all that. If you want to read more, here you go here. This was a tough question. I think people understand that beta 2 agonists can cause transcellular shift of potassium. Now, them putting it together with a pheochromocytoma, that was the challenging part of this question. All right, so our second case to consider, which of the following is not associated with pheochromocytoma? Is it VHL 3P25, neurofibromin 17Q11.2, menin 11Q13, or RET 10Q11.2? So pause your screen and consider. So the one not associated with pheochromocytoma would be menin 11Q13. Now, really, USMLE can never ask you a question like this. They're not allowed to ask you which is not, or like questions like that, because it forces a student to think backwards, and it can often lead to an incorrect answer even when the student knows it, because of like the backwards thinking. You'll see this on a lot of like question banks or practice questions, because it forces the student to kind of jump through hoops, and it makes for a really good practice question, but not a good actual question, right? I like this question because it makes you think through all 4 diseases rather than just finding the right answer and pick it out, right? So really, the VHL is von Hippel-Lindau syndrome, which we're going to talk about. It is associated with pheochromocytoma. The neurofibrinin is a NF1, right? That's neurofibromatosis type 1 that is associated with pheochromocytoma. And then this RET is the multiple endocrine neoplasia syndrome type 2, which is also associated with pheochromocytoma. The MEN1, this menin 11Q13, is seen in multiple endocrine neoplasia syndrome type 1, which is not associated with pheochromocytoma. So I'll probably do a whole lecture on the multiple endocrine neoplasias, but we'll just talk about them in this one too, so we get kind of like a double dip. But MEN1 has my 3 Ps, right? So it's a mutation in this menin, right? And it's got these 3 Ps that classically show up. It's hyperparathyroidism, a pituitary tumor, and then pancreatic tumor, okay? They could have one of them, they could have 2 of them, they could have all 3, right? They'll classically give you a family history of maybe the dad had like a history of hypercalcemia for some reason, right? And now the son is showing up with multiple duodenal ulcers, okay? And then we think about gastrinoma, right? Which is a pancreatic type of tumor. And then the dad has hypercalcemia. Oh, now we should be kind of thinking, right? And when I do my MEN lecture, I'll flesh this out a little bit more. When I think about the MEN2s, right? There's MEN2A and MEN2B, right? The MEN2s have 2 things in common. The 2 things in common are pheochromocytoma and medullary thyroid carcinoma, okay? The 2A then has parathyroid problems, right? Also the hyperparathyroidism, right? I think about it because MEN2A and then parathyroid has 2 A's in it, okay? MEN2B, again, also has the pheo and the medullary thyroid carcinoma. And then the third thing associated with it are these mucosal neuromas, usually on the bottom lip or potentially in the intestinal tract. And those patients may have marfanoid habitus. Okay, so MEN1, not associated with pheo. The MEN2s, both 2A and 2B, associated with this RET proto-oncogene, is associated with pheochromocytoma, as is von Hippel-Lindau, as is neurofibromatosis 1. Not listed here, but neurofibromatosis 2, not associated with pheochromocytoma. All right, if you want to read more, here are 2 articles here. So let's do a physiology refresher. So normally, right, when I think about my adrenal gland, we have the cortex, we have the medulla. The cortex is made up of the glomerulosa, secretes aldosterone. The fasciculata secretes my glucocorticoids. My reticularis secretes my androgens. Inside of that cortex is my medulla. That's where we have our beautiful chromaffin cells that secrete catecholamines, epinephrine, norepinephrine. They're under control of the sympathetic nervous system, right? This is where things get a little bit weird, because normally acetylcholine is the king of my parasympathetic nervous system. Really, here it gets tricky with the adrenal gland. Acetylcholine actually binds to nicotinic receptors, which will actually stimulate the sympathetic nervous system in terms of the adrenal medulla gland. Okay, it is like one of the rare exceptions. The sweat glands are the other ones where it's technically sympathetic, but acetylcholine runs the show. Okay, that's far beyond what I want to talk about today because it gets too far into the weeds. But remember, the adrenal medulla gland is under sympathetic stimulation, and acetylcholine is the neurotransmitter running the show here to cause the stimulation and the release of epinephrine and norepinephrine. All right. So pheochromocytoma is a tumor of those chromaffin cells. The chromaffin cells get a mind of its own and they start secreting excess catecholamines. They typically secrete norepinephrine more often than epinephrine, okay, but we can get an appreciable amount of epinephrine release. And then paraneoplastic beta 2 activity, when this epinephrine and norepinephrine get high enough, we can upregulate the sodium potassium ATPase and cause hypokalemia. All right. So biochemistry refresher, we really are going to take tyrosine and we're going to make norepinephrine and epinephrine. That's our end goal. So we take tyrosine, we break it down into L-DOPA. That's by this enzyme tyrosine hydroxylase, which is the rate limiting enzyme of this pathway. We use a cofactor of BH4, and this is found in the cytosol of the chromaffin cells and the neurons. We then take L-DOPA and we convert it into dopamine. This enzyme is dopa decarboxylase. We use vitamin B6, and that's in the cytosol. We now can take dopamine and convert it into norepinephrine, which is what we want, right? We use the enzyme dopamine beta hydroxylase. We use vitamin C and copper as cofactors, and this is going to be inside secretory vessels. We can then finally take norepinephrine and epinephrine, and we can convert norepinephrine into epi via this PNMT. We use a cofactor called SAM, and then it's found in the cytosol of the adrenal medulla cells, and it's induced by cortisol. So this now gets to the real cool part about the physiology and the pathophys of Pheo. We can now understand, I just told you, norepi is made more often in Pheos than epi, and this is why. So we start with norepi. Norepi is just going to be the base of everything we make, okay? As the Pheo is making more and more norepi, we think about where is the pheochromocytoma in relationship to the other parts of the adrenal gland, right? It's really close. Here's my adrenal medulla, and here's my cortex kind of surrounding it, right? The fasciculata is where cortisol is made. Cortisol induces this PNMT enzyme. So as long as the norepi is in really close relationship to this zona fasciculata where cortisol is in bountiful amounts, we can upregulate the PNMT enzyme, take norepi, throw it through that enzyme that's induced, and make more epi. But as we start diffusing these hormone or these neurotransmitters, the norepi, out into the body and they start doing their stuff, there's less dense amounts of cortisol. Cortisol is going to be really dense right in the adrenal gland because that's where the fasciculata is and that's where the medulla is. As the norepi gets secreted and moves out, yes, we have cortisol throughout our body at different times, but it's going to be less dense and that enzyme's not going to be induced as much. That's why the vast majority of the neurotransmitter produced via the pheochromocytoma is norepinephrine. But at times, right, we can get a big surge of epinephrine right around the level of the medulla, and then it will get released, okay? So my key points for you here is the rate limiting step is that tyrosine hydroxylase. The PNMT is upregulated by high cortisol in the medulla, hence the predominantly epinephrine production in the adrenal medulla. But as the norepinephrine gets spread out, the norepinephrine, right, is going to end up being the vast majority of what we take over, as I showed you here, right? And then the clinical nugget is inhibition of any of these enzymes can alter the catecholamine levels. There is a drug called metatyrosine or met-tyrosine that inhibits tyrosine hydroxylase that can be used in pheochromocytoma prep. I'm not going to talk about it anymore. But again, we take tyrosine, we break it down, or we turn it into norepi, and then norepi can be converted into epi via PNMT, which is induced by cortisol, okay? So when cortisol is really high and really dense, we can get more epinephrine. When cortisol is lower or we have less dense amounts, it's harder to induce the PNMT, and norepi will be the bigger product made. All right, so how does a patient with pheochromocytoma usually present? There was this rule of 10s. It's pretty much outdated, but it can be useful for board exams. 10% can show up bilateral, 10% malignant, 10% extra-adrenal, which would be called paraganglioma, where it's actually one of the chromaffin cells of my sympathetic chain and not my actual adrenal medulla, and 10% pediatric. Again, I wouldn't go about memorizing this for any board exam. It's not really going to help you anymore. We know it's outdated, but it's kind of just helpful to think about like where can these be found and what types of patients. The classical triad, we see our headache, that's paroxysmal, the sweating and the palpitations. You can also see tremor and things like that, right? Sympathetic activation, right? Maybe even some dilated pupils when that norepi and epinephrine are high. Additional clues, We have resistant or paroxysmal hypertension, right? We've got the patient on multiple different drugs and it's still not helping bring down that blood pressure. They have hyperglycemia. Remember, I just did my hypoglycemia lecture and I told you epinephrine is induced when the blood glucose gets a little bit low. And epinephrine's job is to stimulate glycogenolysis and gluconeogenesis to increase blood glucose levels. So when epinephrine is high for a long period of time, or it's transiently up and down and up and down, we can get spikes in blood glucose. We can see the pallor, the tremor, and the weight loss from the sympathetic activation. We can potentially see catecholamine-induced cardiomyopathy or arrhythmias. Usually it's going to be HFrEF with reduced ejection fraction. And then rarely we could see orthostatic hypotension due to receptor downregulation. So norepi loves binding to alpha-1 receptors. When we get these really high bouts of norepi, the alpha-1 receptors on my vessels are like, hey, we don't want you binding. Like, you bound to us so often, we're down regulating, right? We're stopping this process because we don't want to be vasoconstricted as much. Your vessels will down regulate that alpha-1 receptor, which can then lead to some orthostatic hypotension because now I can't actually bind and cause vasoconstriction to these vessels. All right. So what is the diagnostic approach? Kind of this stepwise workup. We'll do a biochemical testing first. So these will be like my screening test. We can test for plasma-free metanephrines or 24-hour urinary metanephrines or catecholamines. Remember, norepi and epi have a very, very short half-life. It's really hard to test for norepi and epi in the serum or in the urine because they have such a quick half-life. They get broken down into these things called metanephrines, which is the breakdown product of epinephrine, and normetanephrine, which is the breakdown product of norepinephrine, right? These have a much longer half-life, and it's a very sensitive exam, okay? So remember, sensitive tests are really good for finding patients with the disease. Specific tests are really good for finding patients without the disease. All right. So seeing an elevated free metanephrines or normetanephrines or elevated 24-hour urinary metanephrines or normetanephrines is a pretty good sensitive test for finding patients with a Pheo. If we see these are elevated, we're like, all right, we're suspecting Pheo. Their clinical context points out, right? They've got secondary hypertension that is resistant to multiple medications. They've got sweating, they've got headaches, they've got weight loss, right? We've kind of all see it. We'll do a CT or MRI of the abdomen or pelvis. We can do uptake scans or PETs for extra-adrenal and metastatic disease. And then again, we can do some labs that might key me in too, where we might see the hyperglycemia or potentially the hypokalemia versus transcellular shift. To manage, right, we're going to want to take these patients to surgery eventually, right? We're going to give an alpha blockade first and then potentially followed by a beta blocker, okay? Alpha first, beta blocker second. That is the most important thing I'm going to teach you in this entire lecture. The reason being, right, when norepi and epi get released, right, they bind to both alpha and beta receptors, right? When I bind to the alpha receptors, it causes vasoconstriction, okay? If I were to give the patient a beta blocker first, we have now blocked, let's say we give them a non-selective beta blocker. We block the beta 1 and the beta 2 receptors. Guess what? This tumor is still secreting norepinephrine and epinephrine. So now all this norepinephrine and epinephrine, they don't have the opportunity to bind to beta receptors. So they're literally just going to go bind to every single alpha receptor that's available to them because that's all they can do. They can't bind to the betas. That's going to cause massive vasoconstriction. That patient's blood pressure is going to be like 250 over like 150, and we're going to be in deep, deep, deep crap. All right. So we give an alpha blocker first, usually a non-selective alpha blocker like phenoxybenzamine, or we could potentially give doxazosin. All right. We usually run that for about 7 days. We check their blood pressure. If their blood pressure is pretty good now, we technically don't have to give a beta blocker. But if we want to, we could then give a beta blocker after. Alpha first, beta second. If we give the beta first, we're potentially going to put the patient into hypertensive crisis. All right. We can do volume expansion with fluid. We'll do adrenalectomy. And then post-op, we're going to look at their blood pressure and glucose. This is a good point where I'm going to tell you, if they give you a question where the patient undergoes surgery and the surgeon just starts or they just put them under anesthesia and all of a sudden their blood pressure gets to be like 250 over 150, you're like, what the heck is going on? They likely have an undiagnosed pheochromocytoma, right? The surgeon cutting into the patient can cause an extreme amount of stress. That Pheo is going to get agitated. It's going to release all this norepi and epi and cause hypertensive crisis. So that's another thing I want you to consider. if they give you a vignette, or if you see this in real life, right? The patient is undergoing surgery and all of a sudden their blood pressure goes super duper high, we need to consider a pheochromocytoma. They'll probably slightly hint at it in the vignette. They probably won't just like jump into it, but they could if they wanted to. So it's something to consider. All right. So these are my Pheo-associated diseases. So we've already talked about the MEN2s, right? The MEN2s, both 2A and 2B, they both have two things in common, the Pheos, okay, and then the medullary thyroid carcinoma, right? The 2A can then have parathyroid hyperplasia or parathyroid adenoma, and then the MEN2B, their third thing is mucosal neuromas or marfanoid habitus. There's von Hippel-Lindau, which is my VHL3P25 mutation, which can have retinal and CNS hemangioblastomas, renal cell carcinoma, pancreatic cysts, and pheochromocytoma. All right. There's neurofibromatosis 1, the NF1 on chromosome 17. They can have cafe au lait spots, neurofibromas, and optic gliomas. And then, of course, pheochromocytomas. But then there's the MEN1. And remember, we said MEN1 with this MEN1 on chromosome 11 mutation is not associated with Pheo. So that's associated with pituitary problems, parathyroid tumors, and pancreatic tumors. Okay. So MEN2, von Hippel-Lindau, and neurofibromatosis 1 are the three diseases commonly associated with Pheo, or Pheo could be on its own. And MEN2, we have Pheo, medullary thyroid carcinoma, and parathyroid hyperplasia for MEN2A, and then for MEN2B, it is Pheo, medullary thyroid carcinoma, and mucosal neuromas or marfanoid habitus. For von Hippel-Lindau, we see retinal and CNS hemangioblastomas. We see renal cell carcinoma. We see pancreatic cysts and Pheo. And for NF1, we see cafe au lait spots, neurofibromas, and optic gliomas along with the Pheo. All right. So if you want to read more, here is a journal article, a great journal article on, really, it's a brand new, right? It was published on May 10th, 2025, on progress in treatment and follow-up of pheochromocytoma. It's a great read. It's what I use to kind of put together a lot of this presentation. We will do one putting it all together, and then we will be done. We have a 3-month-old infant is brought to the pediatrician for follow-up of developmental concerns. The parents report that the child has had difficulty feeding, exhibits delayed milestones, and makes limited eye contact. On exam, the infant is hypotonic with fair skin and light-colored hair, despite both parents having darker complexions. A musty odor is noted. Newborn screening results have not been followed up due to a home birth. Further evaluation reveals elevated phenylalanine levels and low levels of tyrosine. MRI of the brain shows delayed myelination. Which of the following best describes the levels of norepi and epinephrine in this patient? Are they both going to be increased? Is norepi going to be increased and epi decreased? Is norepi decreased and epi increased, or are they both decreased? Take a second, pause your screen, and think about it. All right, so this patient has PKU. So in PKU, there is a malfunction in phenylalanine hydroxylase. There's also a more rare form of PKU where the cofactor BH4 is malfunction. But either way, we have an impaired conversion of phenylalanine to tyrosine. So phenylalanine builds up and it's very neurotoxic. It can also lead to that musty odor, the hypotonic patient, and then the very fair complex. Tyrosine, again, is the backbone, is the precursor for catecholamines, dopamine, norepi, and epi. Without tyrosine being essentially made, we can't do this whole process. We can't convert tyrosine to dopamine, norepinephrine, and epinephrine. So there's data that shows, this isn't just a theory, these patients do have low levels of norepinephrine and epinephrine. PKU, right, we have a malfunction in phenylalanine hydroxylase. So phenylalanine builds up. We can't make tyrosine. Without tyrosine, I can't make dopamine. I can't make norepinephrine. I can't make epinephrine. So both of their levels will be low. So this was me kind of integrating to a whole different concept that maybe you never even thought about. So this was a relatively quick one, right? But we talked all about the physiology and the biochemistry of pheochromocytoma. We talked about some of the associated disorders with pheochromocytoma, and we talked about the management and the workup for Pheo. So this is one, like, Pheo will probably show up on both step exams you take. So could von Hippel-Lindau, NF1, so could the MEN. So be on the lookout for these. Keep practicing them. Reach out if you have any questions, and let me know what other topics you want covered.